conference. My name is Jim Mulshine. I'm a thoracic medical oncologist at Rush University and a longtime member of IASLC. And I have the honor of moderating this session. This is your session. If we cannot explain to you what's going on, you cannot communicate the innovations and the opportunities for improvement for lung cancer, so we're very eager to make sure that this is an effective forum. So we'll start, without ado, we'll step right into this. Our first presentation comes on the socioeconomic factors affecting outcome in non-small cell lung cancer in a large population-based analysis by Yanyan Liu. Thank you very much, Dr. Liu.
So first, I would like to thank the organizer to provide this wonderful opportunity to present our study here. Socioeconomic factors affecting the clinical outcome in non-small cell lung cancer, my disclosure. So this study is mainly collected the non-small cell lung cancer through the National Cancer Database between 2004 through 2013, which included more than 1.1 million patients. So we analyzed the demographic feature, clinical features, and the association with the clinical outcome. So specifically, this study is to look at the impact of race and the socioeconomic factors on clinical outcome. So here is the baseline demographic and clinical parameters by the year of diagnosis. And here we separate by before 2010 and after 2010 in attention to look at the trend over the year. Now it's 68.5 after 2010. And the composition of the patient's race is relatively stable. And predominantly, we can see 86.3% of patients actually are Caucasian white patients, followed by 10.9% of patients are Black, Asian 2.1%, Hispanic 0.4%, and also the Native American is about 0.2%. And when we look at the income, so it distributed to each quarter, you can see roughly about 20.7% of our study patients come from the family with less than $38,000 per house income. And by contrast, 27.1% of patients come from the house income greater than $63,000 per house incomes. And when we look at the educations, we also can find, and has been distributed in the different quarter, and 18.5% of patients come from the low education area, defined by the population residents. More than 21% of the population has no high school degree. And by contrast, 20.3% of patients actually come from the high education area, defined by the less than 7% of patient population without the high school degree in the residential area. And also, vast majority of the study patients are insurance patients. You can see only 2.2% of overall patients has no insurance, and the vast majority of patients has government insurance, and followed by private insurance. But you can also see the trends over the time after 2010. There's an increase in government insurance patient and reduced in private insurance patient. So this is the clinical parameters of this study patient. You can see over time, after 2010, there is increase in the stage 1, 2 patient, and reduced in the stage 3 patient. And the stage 4 patient has been slightly reduced as well. And also, 29.7% of study patients receive the surgery of the primary side, which is most likely is the early stage patient. And also, over time, the number of regional lymph nodes dissection has been increased after 2010 from an average of 8.1 prior to 10 samples lymph nodes dissection after 2010 showed improvement. And also, there is no significant difference between the chemotherapy treatment over the time, roughly about 4.4%. Slightly increase in the radiation therapy received treatment, and the vast majority of patients come from the metropolis, roughly represent about 81.7% as compared to urban 16.1% and rural area is 2.2%. and roughly about 30.3% of patients received the treatment in a high-volume facility, defined by 90 percentile of the case annuals. And also, more than 59.4% of patients has the low Charlson comorbidity scores. So when we look at the multivariate analysis of the race and the socioeconomic factors and association with the overall survival for non-small cell lung cancer, interestingly, we found that as compared to white, the black patient actually had a ratio was 0.947 after we adjust all of the above socioeconomic and treatment clinical parameters. But more strikingly, we found as compared to other races, Asian patient and Hispanic patient actually has a better clinical outcome, particularly in the Asian patient. And also, not surprisingly, the comorbidity score has been actually associated with the poor outcome, meaning more comorbidity and worse outcome. And the family income has also been shown to associate with the overall survival. Higher family income, better clinical outcome. So here is also the education association with the overall survival. As compared to the patient who come from the low residential education area, the patient who come from the high education area, defined by less than 7% of the patient has no high school diploma. So this should slightly improve the overall survival. But I think more strikingly is with the insurance. As compared to uninsured patient, the government insured patient has improved the overall survival, but particularly more in the private insurance patient with hazard ratio of 0.8. So as compared to metro patient, the urban and rural has showed a slightly worse outcome. So the take-home message from this study is we found Asian and Hispanic patient has better clinical outcome than other race, and the insurance status, particularly the private insurance, income, education, and location, were found to influence non-small cell lung cancer survival in this multivariate analysis of the adjustment of multiple parameters. And this study indicated equitable health care delivery needed to be addressed to help to improve the clinical outcome for non-small cell lung cancer. Thanks for your attention.
Thank you very much. We'll hold the questions to the end of the session. And so we'll next hear from Fraser Brims, who will be talking about RESPECT-MESO, an international randomized controlled trial to assess early specialist palliative care in malignant pleural mesothelioma. Thank you.
Okay, good morning. Thank you very much for the invitation to speak. So I'm just going to give you some of the early preliminary results of a study to examine the effect of regular early specialist palliative care on patients with mesothelioma, otherwise known as RESPECT-MESO. The funding for this study is from the British Lung Foundation and Australian Communities Foundation. Got no other relevant conflicts. So malignant pleural mesothelioma is a cancer caused by exposure to asbestos. It has a very high symptom burden. It's relatively resistant to treatment, and generally the average survival is less than 1 year. There's been a lot of interest in recent years following a paper in the New England Journal 2010 about the role or the possible role of regular early specialist palliative care in patients with advanced thoracic cancer. This paper demonstrated an improved quality of life in patients with lung cancer. And that there's a lot of crossovers in terms of the outcome and the symptom profile with lung cancer and mesothelioma. So we performed a randomized controlled international study over 24 sites, predominantly in the UK and one large recruiting site in Western Australia. There's over a 2.5-year period. We offered to the intervention group regular early specialist palliative care with a consultant palliative care physician, regardless of any perceived need. They all went there, and they all had an initial assessment, and then they were seen every 4 weeks throughout the study. The primary outcome was looking at quality of life at 12 weeks, which is obviously a patient-reported outcome measure. And other measures were looking at anxiety and depression and survival. I should add, we also recruited the patient's carers as well, where we could, although these data aren't available yet. I haven't even seen them, let alone being able to present them. So we've recruited 174 patients. They're a relatively old cohort and a strong male predominance as expected for an occupational disease. So at 24 weeks, 17% of the participants had died, and by the end of the study overall, more than half our cohort had died with a median survival of exactly a year. So the primary endpoint is this. So at 12 weeks, there was no significant difference in quality of life between the two groups. There was no difference in quality of life at 24 weeks. There was no difference in anxiety or depression scores at 12 or 24 weeks. And as we expected, there was also no difference in survival. So at first I was disappointed by this, and then I got thinking, is this a real effect? Well, we think in terms of the trial design and the quality of the data and otherwise that it is a real effect. We haven't had a lot of unexpected events as part of the study, so we think it's real. And then we have to ask ourselves, well, why do we think it's real? I think primarily if we look at the current provision of care in Australia and the United Kingdom, as well as expert clinicians, we have senior specialist thoracic cancer nurses and chemotherapy nurses who support the patient in their journey. And that's standard care now. So it is possible, therefore, that the addition of specialist palliative care to all comers, regardless of any perceived need, just hasn't made that much difference to the patient's unmet needs. So in conclusion, regular early specialist palliative care for all patients with recently diagnosed mesothelioma is not associated with beneficial changes in quality of life. And to take one step further, therefore, it is likely that our current standard care in Australia and United Kingdom is meeting patients' needs adequately. Why did we see a different signal as compared to the large American? Well, it was a single-center American study. I think it's probably those two reasons. One, this is multi-center and it's sampled a larger population. We're also looking at a different disease, but also it's a different healthcare system. And that may well be the underlying reasons why things are different. So our key points are summarized here. It's a high burden of symptoms for mesothelioma and a short survival. This is a large international study looking at a patient-reported outcome measure of quality of life. Our intervention was regular early specialist palliative care regardless of any perceived need for the intervention group, and they got that every 4 weeks. Ultimately, there was no difference in quality of life or mood throughout any of the study, and therefore, by conclusion, we can say that there's no effect to the intervention and that current standard care is likely to be adequate. Thank you very much.
Thank you very much. Our next speaker, we just came over from the morning plenary session, is on the major advances in CT screening, a radiologist's perspective. This is Professor Claudia Henschke.
How many minutes?
5 to 10.
Okay.
I'm sure
But how do I? So I want to compliment the IASLC for making steady progress. There's really been a lot more interest in CT screening for lung cancer, and there have been updates to screening protocols and talking about further outreach to people at risk of lung cancer. There seems to be acceptance of the fact that screening is more than just looking for cancer. It's looking at many other aspects that you find in the chest. There's recognition that quantitative assessment of those findings is important, and that it's important to bring together the global community to really advance all aspects of screening. Just to give you a perspective, we started on these little images that we saw. We had 30 images per person, and now we have more than 800 images on a person, and we can reconstruct and look at them in many different ways. So there have been remarkable advances in CT scanners. There have been recognition that quality standards and monitoring are important, and there are organizations in the US, the American College of Radiology, and the physics group that are really looking at how to set the standards for the acquisition and for the monitoring of quality. There's global collaboration. There are new screening programs being initiated worldwide that we heard here. There's in China, They're large programs, and whenever something starts in China, it really has a big group that they look at. In Europe, screening is still not done, but there's progress in planning for the implementation. And in the US, we have recommendations for CT screening, but we're now also providing it more for the Veterans Administration in the US, which is the largest single-payer system in the US. There have been management protocol advances. It's very important of how do you read that first CT scanner and when do you provide further workup. You want to minimize unnecessary workup and maximize finding the lung cancer earlier. And so there's been continued advances in volumetric assessment. All the protocols believe that you have to have continuous updating, and they're competing protocols, but that's useful because it helps really develop the data moving forward, and those discussions are important. So we do the International Early Lung Cancer Action Protocol, which we've started accumulating data since 1992. The Nelson has been working and collects data. There are guidelines by the National Comprehensive Cancer Network, NCCN, and then there's the LUNGRADS, which has been developed by the American Cancer Society for screening, and the Fleischner guidelines exist for nodules found outside of screening. And we can compare many of them as we see here, and that's important because there's ongoing quality assessment. What isn't really recognized is that CT scanners provide beautiful images, but for quantitation, it's maybe not as good. So here you have a simple roll of tape that is very well designed to be round because it has to fit on those dispensers. But when I take it from the center of the CT scanner and move, in this case, it would be like a nodule moving to the periphery, look at the warping that you have. So that makes quantitative assessment still not where it should be, and that has to be further improved. And the Radiologic Society of North America is working on that with various projects. So volume assessment of nodule to assess growth is really the way of the future, and we had started that, showing these very nice images where you can look at nodules at time 1 and time 2. You can estimate volume doubling time. It provides a very useful method for really assessing who has a malignant nodule or not. And we can do all sorts of other things, but at the heart is really that it needs to be done very carefully. It's been used routinely in the Nelson study, but it needs much further development. It needs confidence intervals about each nodule assessment, so there's much more that has to be done. In the future, you've probably heard about radiomics. That means take radiology and genetics, and that really gives you a tremendous amount of information, but it requires a tremendous amount of computer capacity, and you have to have both images and the genetics. So large databases will facilitate this in the future, and so you can automate the entire CT. You take that scan, and actually we could produce this report on everybody within minutes after the CT scan is taken. You can look at the aorta, you can look at the ribs, you can look at the, well, these are the pulmonary vessels, you can look at the aorta, you can look at the body, you can look at the breast and the liver. So there's a tremendous amount of information that you can gain quantitatively. And so I think that we should really think about screening as an annual health check. The costs are going down, the radiation is going down to that of a chest x-ray, and we can look at all of these organs in that single check. We can diagnose other diseases, usual interstitial pneumonitis, which if you have it, has really you die more quickly of it than from lung cancer, but if you detect it early, there are things that you can do. Emphysema, cardiac disease, secondhand smoke exposure gives you, increases your risk. You can look at the breast and the adrenals. And there's importance in looking at what the optimal strategies for treatment of these small early lung cancers that you find. There has to be continual updating on that optimal treatment. There are trials ongoing in Japan. There's several trials and one in the US. But we also have to have an ongoing evaluation of how the treatment should be done because the lung has only 5 lobes. So how many lobes can you take out? You're going to have tremendous evolution of the type of treatment that you can give. Just like for breast cancer, you used to do radical mastectomy with lymph node dissection. Now we have much more nuanced treatment. And that same process, which took 40 or more years, hopefully with international collaboration and all working towards the same goal, we can shorten that and provide better techniques for people earlier. So the take-home message is that we've come a long way since we started screening in 1992, but there's still much more to be done in the development of all aspects, and that really requires international collaboration. And we're very happy that the IASLC is taking that as one of their goals. Thank you.
Thank you, Claudia. We're next moving on to a presentation on smoking in Japan, and the presentation would be by Yumiko Mochizuki.
Thank you.
Thank you very much.
Thank you very much for your introduction. My name is Yumiko Mochizuki from Japan Cancer Society. I'm quite new for IASLC, but I'm very much enjoying this conference. I changed the given title to Emerging Epidemic of Novel Tobacco Products, Heat Not Burn, and the concept is now burning in Japan, and a new horizon of tobacco control. I have no conflict of interest to disclosure. So this is the current epidemic of cigarette smoking in Japan. And then you will see that dramatic declining of smoking prevalence recently. And then the right-hand figure is showing the total population of smokers for men and women. And good news. And then curbing the epidemic in Japan is clearly shown. And we had WCLC 2000 in Tokyo, and then it worked because they released the Tokyo Declaration, Kinyen Tokyo Sengen, and after that, and then Japan Lung Cancer Society and also other major medical societies stood up to declare their own non-smoking declaration. And also that kind of movement clearly definitely mobilized the local citizens, and then NGOs and NPOs were emerged. So anyway, since 2010, thanks to the former president of IASLC and WCLC, they helped us a lot. But bad news is that I took this photo in Tokyo, in Ginza, and that is an emerging new product, heat not burn. And then the industry's statistics shows that Japan sells most of their global sales. And then we have now 3 different brands from 3 major multinationals. And IQOS is one of the most known products. And then now this year is head-up year. And then I just show you the 2 gadgets and the mobile smartphone. And then because those products just fit to our market in Japan and just to fit the Japanese sensitivity to gain the most cutting-edge design, and then that is the device. And that device does not only mean the mechanical tools, but the paradigm change is now seen. And then tobacco industries has spent almost 50 years for investment and also the R&D, and then the deception to the public, and deception to the government, and even deception to the medical societies. And then just they wanted to achieve the particular purpose and aim. What's that? That is just maintain and expanding their market and increasing their profit. And then tobacco industry is already known, and they are selling just drug or nicotine, and then they themselves wanted to be called as a drug industry or nicotine industries. And then for that purpose, they modified and designed their products to be more attractive and acceptable. And then now, Japan, where tobacco business is highly regulated under the Tobacco Business Act that is owned by the Japanese Finance Ministry, not Health Ministry. But tobacco products have never been regulated in public health purpose, never. And then I just do the Google trend analysis, and like the recent paper and by the other person. And then Google trend analysis shows the very popular phenomenon like the infectious disease. And before, the actual statistics from epidemiologists will be seen. So I use 3 keywords: IQOS, Plume Tech, Grow, and then their competitors, e-cigarettes, and smoking cessation. And then unlike the world, and that was only 3 years ago, and Oxford Dictionary selected vape was the word of the year. But that year, we have never seen the in Japanese dense tobacco or e-cigarettes in the Google analysis. And Japan is where e-cigarette and smoking cessations are unpopular, and I'm very sorry to say that, and that they are very hard to access. And e-cigarette with nicotine is highly regulated. It is actually illegal because we have the poison and toxicants regulation, and then if they need to sell that, and they got the approval as a medication, but they didn't. And then also we have more than 100,000 of cessation clinics nationwide, but its access is very, very limited, and it's highly expensive. And then, but when you see the convenience stores at streets, they are like 7-Eleven and 24 hours and 365 days sellers are available. So compared to that situation, tobacco is very, very accessible. And then those products, heat not burn product, attracts all segments in the society. Of course, they are targeted smokers, and then smokers are given the wrong information. And then most of the smokers who are using the newly cigarettes who would like to quit. But instead of going to the cessation clinics, they are just purchasing their product at convenience stores. So that means that prevent quitting and increase addiction, because those products are highly engineered. And then that is the IoT device. So device itself is regulated the smokers or users' attitude. And then there are microchip embedded in the device, and then they are collecting the personal data and then their smoking behavior. And then once the device is broken, and it can be changed, it should be changed as the retailers. And the old information embedded in the device will be used by the makers. So there is a very tiny disclosures that once they send the broken device to the retailers, that means that users will be given the informed consent for their private data to be used. And then also it attracts the non-smokers because it's claimed and there would be no limited every second hand smokes. So now Japan has no national regulations public smoking, and only 2 prefectures have the smoke-free ordinance. And then Tokyo will be the 3rd. And then, but under that discussion to develop the policy, this newly developed product is not written clearly, because those existing legislation is based on the cigarette or conventional tobacco products. So it's so brand new for the legislator to apply the existing policy framework onto the new one. And then there is a tiny city in Kyushu area, and it excluded this heat not burn for their non-smoking ordinance on the streets. So that kind of controversial debate is now happening. And also, they claimed that there will be a very limited residue of chemical substances, and also no ash or no dirty, and that would exceed the stigma given to the users. So these are the areas where new products are now embedded in the society. And that means both tobacco companies forecasted their market share will be increased by 50% this year. So New Horizon and tobacco ban of smoking at home in front of children, including heat-not-burn, is just passed. And then Tokyo Metropolitan Government would like to expand their focus to include public places, but nobody knows. And also a New Horizon is coming from the patient advocates, and then they themselves empowered, and also they themselves are empowering the whole society. And in this year, I hope WCLC would also work to curb this epidemic again. So take-home messages here: an emerging tobacco epidemic to influence all sectors, and urgent need to apply rigid regulatory framework like USA or the other countries before they reach to a point of no return, and synergy with patients' voice to empower tobacco control advocacy. So thank you very much. And I'd like to introduce Mr. Hasegawa as one of the key lung cancer patient advocate.
Thank you. Thank you. In our final presentation, and then we'll have discussion, will be on cost and cost effectiveness of smoking cessation within an organized CT lung cancer screening. And this will be delivered by Professor William Evans.
Thank you, Jim, and thank you for the opportunity to present here at this press conference. As soon as my slides come up, I'll speak to them. Do I have to do something?
Yeah.
What do I do? I'll do that, and that's this one. Oh, okay. And forward here? Okay. So this is work I'm presenting on behalf of collaboration between the Canadian Partnership Against Cancer, which is our Canadian National Cancer Control Agency, and Statistics Canada, which is a federal organization that has the computational power and also the brain power to create sophisticated microsimulation models. And what we have created is something called OncoSim. It's a microsimulation tool that can be used by decision makers to determine whether new cancer control measures should be introduced in our country. And specifically in this case, we know that lung cancer screening can reduce lung cancer mortality, but what would be the impact of introducing smoking cessation within that in terms of cost and cost effectiveness? We know that lung cancer screening is a teachable moment, and patients will be, or individuals will be showing up annually to have a screening done. And if they're a smoker, it's an opportunity to speak to them again about the hazards of smoking and to use an aggressive approach of smoking cessation, including nicotine replacement therapy, varenicline, and counseling over a 12-week period. And so we have factored these into our microsimulation model. And as you can see, with different rates of smoking cessation or quit rates, and we have factored in these as permanent quit rates, you would see a reduction in the incidence of lung cancer. It obviously varies with the quit rate, and we don't really know what the quit rate optimally achieved in the context of a low-dose CT screening program would be. So we've looked at it over a range from 2.5% all the way up to 20%, which some may see as optimistic. But these individuals are motivated to come and have CT screening, so maybe they're also motivated to quit smoking. And what you see is a reduction in the number of lung cancers, but you might also say, well, the number is actually relatively small. And this is based on Canadian data. So if you took it to the American context, you could multiply that by a factor of at least 10. So it'd be over 3,000 individuals who would avoid getting lung cancer annually over a 20-year period. Now, you have to acknowledge that smoking cessation does not immediately lead to a reduction in lung cancer. And the model, in fact, phases this in with a lag time of over 10 years. We also can model the effect on mortality, and you can see that the average lung cancer mortality will also vary with the smoking cessation rates. And with no smoking cessation, you would have this number of over 23,000 deaths in Canada annually, declining with a higher smoking cessation rate of 20% down to 23,000. So it's a drop, but in fact, percentage-wise, it's relatively modest. And you can see from the mortality curves that they continue to rise, because that's the nature of the demographics of Canada. We have a population with a large, we call them baby boomers, people born post-war that are moving through aging. Many of them have been smokers, and so mortality continues to rise. But with various rates of participation in the screening and adherence to screening, you can see that there's a different impact. So with low rates of recruitment, 20%, and low adherence rates, 50%, and a low smoking cessation quit rate, you get the highest mortality. Whereas if you could achieve an 80% recruitment rate of the smokers and a 90% adherence and a high quit rate, then you could see that you would reduce the lung cancer mortality. And when you get out to about 20 years, you start to see a significant decline in lung cancer mortality overall. But it comes at a cost. And so what we have looked at is the cost of both the screening program, the lung cancer treatment program, and that's the biggest cost, and we have to bear that in mind. Treating lung cancer is an expensive proposition, and in our model currently, that's based on 2010 treatment practices. And since that time, we've had the proliferation of molecular targeted therapies and now immunotherapy. So we are in the process of updating our model, and we'll see that treatment costs increase substantially. But adding smoking cessation will add a significant cost. But at higher smoking rates, what you see on an annual basis is that the total cost will decline because you'll have fewer smokers, so there'll be fewer requirements to introduce the aggressive smoking cessation initiative. So a conclusion is a robust smoking cessation initiative allowing multiple quit attempts, and we go up to 10 quit attempts in our model, within a low-dose CT screening program could save lives while costing somewhere in the order of $14,000 per quality-adjusted life year. To put that in some context, various countries use different thresholds for cost effectiveness, but at a minimum in our country now, we would say $100,000 per quality is an acceptable level for a healthcare intervention. This is well below that, so it's a highly acceptable cost effectiveness ratio. Is this important? Well, in publicly funded healthcare systems, we have to make a decision about how to use our resources. And when something is cost effective, then governments are much more inclined to accept the new intervention. And so when we compare to just smoking cessation without any, or low-dose CT screening without any smoking cessation and put it on the graph as the red dot, you can see that when we have a recruitment rate of around 60% phased in over 10 years and an adherence rate of 70%, and a 5% quit rate, you get this $14,000 per quality outcome. But at higher levels of cessation, you get even more favorable cost effectiveness ratios. And so at the 20% smoking cessation rate, it'd be a minimal level of cost effectiveness at around $2,000 per quality. On the other hand, when you have low recruitment rates, then you have fewer people to work with, and it doesn't matter whether you're got a 5% or higher, you're not going to get as much benefit. And if you are really low in recruiting to your smoking cessation program at, say, 20%, which might be the case in an opportunistic situation, and low adherence, then you get a very ineffective cost effectiveness ratio. So the argument really is you want to achieve a combination of high recruitment rate, high adherence, and high smoking cessation to get the optimal impact. And it's not just producing cost effectiveness as a result of lung cancer reduced incidence and mortality, because our model incorporates all-cause mortality. So we're getting less heart attacks and deaths from cerebral vascular disease and chronic obstructive airways disease, which really is what accounts in large measure for the very cost-effective numbers that we're seeing from our model. So with that, I'll stop and field questions, and thank you very much.
Well, thank you very much. Those were 4 beautiful presentations on a spectrum of issues. So we're here now to answer your questions. If people have questions, if they could come to the mic, I think our panel is ready to address your questions. Well, one of the things that occurred to me in just hearing, Bill, your presentation, was that having that kind of information available in Japan, customized to the Japanese situation, would be profoundly powerful because those numbers are remarkable. And people think it's a massive cost, and in fact, there's a real opportunity here to manage the 3 major causes of premature death and cost in many societies with this approach. Is there a possibility that you could apply this kind of analysis in other national settings?
Well, in fact, the model is open access, and it's available through, and I'll leave some cards for individuals who are interested about contacting the Canadian Partnership Against Cancer and accessing the OncoSim model. But every jurisdiction has to modify it appropriate to its own healthcare system, and there are important differences here compared to, say, the Canadian situation on how you manage lung cancer patients, including very high and long hospitalization rates. And so those things would need to be factored in. I would hazard from my limited knowledge of the Japanese healthcare system that, in fact, smoking cessation in a low-dose CT screening program would look even more cost-effective, because I think your treatment costs are much higher. And this would be an important way of reducing those treatment costs over time for lung cancer, as well as avoiding the other health-related smoking diseases.
Thank you. Do we have a question?
Hi, Karen Reckamp, United States. Thanks to all of you for your presentations. I think that, smoking cessation, screening, quality of life, they're at the foundation of what we need to do in order to help people and potentially cure or prevent lung cancer or other types of thoracic malignancies. So this is really great. I wanted to ask a question to Dr. Liu. It's interesting to see the differences between healthcare across multiple countries, and what's disheartening is to see over and over again that socioeconomic status and public insurance, basically, public insurance is almost as good as no insurance, and the majority of patients are either dealing with public insurance or no insurance. So can you speak to that and certain ways to fix that? I know tomorrow they're going to talk about the same kind of thing with small cell lung cancer. So it's endemic in the US that public insurance and no insurance is a big problem to getting quality care.
Sure, thanks for the questions. Yeah, so actually that's the most striking results when we analyze the data. We see the patient who received this through the private insurance definitely has much better clinical outcome as compared to the non-insured and government-insured patient. I think likely the reason is due to the access to the healthy care, and so for the private insurance patient, they have more access to the academic center and other multidisciplinary care, and they do get better cares. So I think the key is here is try to improve the patient to access to the multidisciplinary and other cares to make the patient who has uninsured patient who has more accessible to the same care. So that would be the key. Yeah, thanks.
Thank you.
Jim, could I comment too?
Yeah.
Just on that question. Because I come from a country with universal health care access, but there are major equity issues nonetheless. So we can deal with the funding issue for health care, but you still see disparity between socioeconomic status, immigrant status, and to some extent gender. And the difference between rural and urban is a little less marked in our situation, even though we're a big country with a small population, but it tends to be concentrated around where there are good healthcare facilities. So I actually have just been reviewing this in Cancer Care Ontario, and I'm quite struck by the variation in access on these metrics, even in a universal healthcare system. So we got a lot of work to do.
Yes, thank you. Thank you. Carolyn?
Carolyn Dressler from the Human Rights and Tobacco Control Network. And this question is for Dr. Matsutsuki, because I understand the Olympics are coming to Japan in 2020, and they're supposed to be in smoke-free countries. So what is Japan doing to go smoke-free and indoor smoke-free? And how can we make that happen?
So WHO, as you know, WHO and IOC had an agreement to make the host city or host country to be tobacco-free. And under that direction, and then even the national government or the local governments are now moving on. But unfortunately, the Minister of Health wanted to make a proposal to pass the national legislation and to make the public places and workplaces smoke-free. And there, as you know, there are a lot of political debates and going on. And then the leading leader of the health sector has changed, and that personal change has happened. And then the current Minister of Health changed the direction, slightly fits the tobacco industry's demand. And then, so that is some delay technique, or even they wanted to invest the huge amount of money for the smoking rooms. So that is now happening at the national level. And then now there will be a new election, and then nobody knows who is taking the lead of this society. So I trust the local initiatives rather than the national initiatives. And then there are a lot of good governor of prefectures like Kanagawa or Hyogo, and then now the Tokyo metropolitan government. So under that local initiative, we can push, we can encourage those policymakers at local levels. And for that purpose, and as I concluded in my last slide, and the patient advocacy and also the civil societies should set the visible goal. That is not a compromise goal. And I dare to say tobacco-free, not smoke-free, because smoke-free is now frequently used by the tobacco industries, just to designate the non-smoking and smoking areas, just to introduce the heat-not-burn product. So that smoke-free words are now used or hijacked by the tobacco industries. So this is what I'd like to alert to the audience.
Other questions? Yes, please.
Thank you. Question for Dr. Brims. Congratulations in completing such an excellent and important study for meso patients. Sanjay Popat from London. My question is about your findings. So very surprising finding that there's no benefit. Why do you think that there's no benefits? And if specialist palliative care isn't for everybody with meso, then who is it for?
So we've looked at aspects of trial design. I'll be talking about this in 3/4 of an hour shortly, but we don't think it's a quirk. We don't think we've missed a real effect. There's no trend in the data, which I'll present shortly, to say that it was underpowered or we didn't quite have enough patients or we chose the wrong choice of endpoint. So as I alluded to, I think it is a real effect, and it perhaps in a good way, it reflects that actually the current practice is acceptable for those who don't have that high burden of symptoms. And in our group, 37 were excluded because they needed referral to specialist palliative care at the time of recruitment. So where does it leave palliative care? Well, I think, as you know, there's a big study in the UK running. There's one in Australia looking at non-small cell lung cancer, multi-center studies. It'll be very interesting because the healthcare system in the US is very different to many other healthcare systems. So I think it's right that that is being tested, and it will be fascinating to see what the outcomes are. The one bit of data we haven't got yet, as I've said, is with carers. So we're looking at not only their quality of life, depression, anxiety scores, but also their preference for care as well. So I weight that with interest, but it is a secondary outcome ultimately. Thanks for your question.
Thank you. Additional questions? Yes, please.
Hi, I'm Jocelyn from Malaysia. My question is to Dr. Brims. Perhaps would a longer duration make a difference in the study outcome? And another question to Dr. Liu would be, is there any working theory?
Let's do one at a time.
Oh, okay, sure.
So a longer duration of follow-up,
Yep.
do you mean? Yeah, so we followed them out to 6 months to 24 weeks, so by which point, there's becoming a sort of 1 in 5 dropout from death. So to show an effect in a scientific clinical trial is going to be hard in that respect. I think this study isn't questioning whether specialist palliative care has a role in complex cancer. It definitely does. It's just trying to understand where in the trajectory of the disease it has a role. And I think what we can see from this study is that it doesn't have a role early, soon after diagnosis in those who don't have that higher symptom burden.
Your second question?
And my second question to Dr. Liu would be, is there any theory as to why clinical outcomes are better in Asians and Hispanics?
Yeah, so I think this is likely due to some biological differences. As we know, Asian patient actually tends to have more mutation status like EGFR. And interestingly, some published data also show that Hispanic patient also has similar trend. They tend to have more mutation status. So biological is different, I think.
Additional questions? Dr. Henschke, you had just in the previous session pointed out that one of the sets of pioneers in CT screening for lung cancer was the Japanese investigators. And in fact, they were pioneers in chest X-ray early detection as well. And as we just heard, they have superb surgical management with tailored, minimally invasive approaches. It would seem that some of the opportunities for screening in Japan are very, very rich, given the recent drop in the smoking rates. And with the shifting epidemiology around that, they will have a higher frequency of lung cancer versus cardiovascular disease in those populations. Do you have any thoughts about how we can energize screening in our host country here?
In the Nagano project, but just before that, Dr. Kaneko in the National Lung Cancer Institute in Tokyo had introduced, they had a chest X-ray screening program throughout Japan, actually right after World War II. They did it, set up those clinics initially for TB screening, and then when TB could be treated medically, they said, we're changing it to lung cancer screening. So they're really the first country to do national screening in a systematic way. And then there was a lot of discussion about introducing CT. So the Dr. Kaneko introduced it in Tokyo and Dr. Sone in Nagano. And then there's been discussions about having it available in other prefectures. But then it depends on the availability of CT scanners. I think overall they have a good system in place. They have a good outreach to the population. They screen people 40 and older who are smokers and never smokers, so they have a wide criteria for enrollment. So it's really a matter of having more CT scanners becoming more affordable, because you can do the scan as quickly as you can a chest X-ray. I don't know how to stimulate other than actually the governors. There were leading people at the opening session yesterday. So maybe there should be more advocates really who push for screening. I don't know what the advocacy program is in Japan.
And now I'm working as the Japan Cancer Societies, and we have a sub-organization nationwide, and most of them are running lung cancer screening systems, as you mentioned, but they are never used for smoking cessation. And then there are a lot of controversies across the nation, and especially because of the cost effectiveness. But having your results combined, and then I think we can mobilize the public attention and also the medical attentions to introduce the new screening plus intervention systems. Because as you told, and we are so much exposed to smoking in the past, and there will be more lung cancer patients. So early detection to prevent the unnecessary death for cancer patients is very, very necessary. And I'm a prevention person, but of course that kind of combination should be more encouraged.
So how can we use this meeting forum to help you?
Help me, okay. And then I think that we have the government-driven just screening system, and then, but at the same time, local city screening systems are used by clinicians. So I think, and then maybe we can approach the City Screening Academy in Japan, and also encourage the medical societies and who will be more interested in that kind of approach. Because screening and preventions are never combined into this community. So having two good approaches is very important.
Now,
Well, I would think that the Olympics, I didn't realize that the Olympics had those pilot requirements. So I think that would be a wonderful way to bring sports people and to help you.
Yeah, thank you.
yeah, we personally could boycott the Olympics. We wouldn't run or jump
Yeah,
or swim
that
unless
is-
it goes smoke-free. Any further questions? If not, I would like to thank all our presenters for their wonderful efforts to help move forward lung cancer outcomes and mesothelioma outcomes. And I thank you all for your attention.